Okay, everybody, sorry for the confusion earlier. We're going to go ahead and get started. So thank you so much for joining us this afternoon for this track, which is focused on designing better experiences for patients and care teams. We know that patient experience and clinician experience are intertwined and interconnected. And the better prepared and comfortable a patient is for a visit, the better it will go. And on the other side, the less stressed and more focused clinicians are, the better that the visit is going to go. So the two work in harmony. And as a matter of fact, we're seeing an evolution in design from human-centered design, which considers the need for utility, toward purpose-driven design, which aims at achieving social impact and measurable outcomes, of course. And another interesting evolution in design is in the direction of relationship-centered design. And this looks at how we might optimize relationships between people so that interactions happen at the right moment with the right context and with the right level of support for each person. So our focus on this track is improving experiences for everybody involved with care. And we're going to start out with a story of a team of non-designers, quote unquote, from Kaiser Permanente. And we're going to learn how they were able to improve the experience for their patients and clinicians at Kaiser Permanente. So would like to introduce you to our first presenters. Kelly Dumke is a senior learning consultant at Kaiser Permanente, and Angela Shumaker is a senior consultant at KP as well. They're going to share challenges and successes with you, and I can't wait to hear more. So welcome, Kelly and Angela.
Awesome. Thank you for having us. Just a quick sound check. You guys can hear me okay? Awesome. Good morning, good afternoon, wherever you are. We are excited to share our story at Kaiser Permanente for reimagining health promotion and behavior change with patients, lessons learned from former non-designers. So if you look on the right-hand side in the polls section, I dropped a poll in there because I want to hear from you guys. How many of you are designers by trade? So there's kind of three options there. You're a designer by trade. Maybe you're not a designer by trade, but you've had some training or are fascinated by the field. Or this is a weird question, Kelly, I don't want to identify, which is totally fine too. So if you guys pop those up, just kind of answer that poll real quick. Awesome. I'm seeing some results come in. So it looks like we've got a different, kind of a mixed group. Awesome. Perfect. Great. Well, hello, everyone. Great to kind of get a little bit of read of the room. If you haven't figured out from the title of our talk, are not designers. I'm a public health practitioner by trade. I have my doctorate in systems change and chronic disease prevention. And Angela is a registered dietitian by trade with a really strong foundation in healthcare operations. And I say this because I want you to know where we're coming from today and from our story and how we've been able to incorporate human-centered design into our tool belts, and it has truly changed the way we do our jobs. And for that, I really want to give a huge shout out to the design consultancy at Kaiser Permanente who trained us in human-centered design. The compass I'm sharing you on the screen is the model that they have built out, and I'll kind of talk more about that later. But again, just a huge shout out to that team. And if you're curious at all about any of their methods for training and spreading human-centered design through a massive organization like Kaiser, please let me know. I'm happy to connect you with them. They are a wonderful team of true designers. So I want to jump into our official problem statement to kind of give you the design brief of where we were coming from in this project. So what I'm popping up right now is our official problem statement. Bariatric surgery is a powerful weight loss tool for qualifying members, but it also imposes major lifestyle changes. And this project sought to reimagine bariatric surgery education and aim to improve long-term engagement across the entire arc of care. That's the official problem statement that Angela and I give to our leadership all the time. But I want to tell you the real story of how it actually went down. So scene was January 2018. Our leadership came to us, Angie and I, and said, can you build a bariatric surgical preparation program that takes into account the diverse medical needs of our demographics and of our patients, our clinical regulatory guidelines, how histories of trauma impact patients, the limitations in staffing in medical centers, and you're probably not going to get any more budget to do anything with that, the need for consistency for the Department of Managed Healthcare, oh, and can you figure out what human-centered design is and then use it to figure this out for the largest bariatric surgery provider in the world, Kaiser Permanente, Southern California? And this was our reaction. Wait, what? That is how we embarked on this journey to really reimagine the preparation and support program for our bariatric patients at Kaiser. But little did we know in 2018 that this project would actually transform the mindsets and methods used to design chronic disease programs at Kaiser Permanente Southern California's Center for Healthy Living. So I want to kind of give you the goals for our talk and our little bit of a roadmap for the next few minutes. Our goal really is to give you a practice-based examination of how we have been using human-centered design to rethink how we design health education and behavior change programs. But we want to share it from the story of designing with our patients, but also using human-centered design with design within our systems and our staff, as well as some key takeaways and tools. So I'm going to dive right into designing with our patients and really sharing the story of how we kind of followed this human-centered design compass. It's going to look linear. It was not, I'll tell you that right now. But I'm going to take you through our journey very briefly. This is the high level, so we're going to zoom right into our understand phase. So we started off working with our patients. We recruited about 100 members who have gone through bariatric surgery at Kaiser Permanente Southern California, which is a massive region ranging from southern San Diego to Bakersfield. We also worked with our bariatricians, our surgeons, our nurses, as well as our mental health professionals, all the folks who touch these patients along the care pathway. We did a series of different things. We used co-design, where we actually hosted 9 co-designs over the course of a year to really understand and think through solutions together with our staff and patients in the same room. But one of the things we also did was a series of ethnographic interviews, because we knew that folks who were struggling with the surgery or who had barriers with the surgery weren't always coming to our co-design sessions or didn't really want to come to a public forum. So we really did some outreach to make sure we're getting those folks that we don't always get to volunteer to come to something. We also did a series of observations and workshops that were existing interactions with patients, really to just understand needs. And you can see on this slide some of the things that came out of it. Really, no one patient was the same, and really there were quite a few different types of folks going through this surgery. So moving into that reframe phase, which is probably the most important step, I think, that has really changed the way we practice, because in healthcare, we're trained to be problem solvers, that quick fix, that jump to those solutions. But that reframe phase of really stepping back to really think about what we heard and learned. We learned so much from these patients, which are kind of summarized in these 8 key insights. So all those co-designs, all those interviews we did are kind of summarized in these 8 insights. So the first one is that why we gain weight and how that was different for all of our patients. The second one is the socio-ecologic context, which is a fancy way of saying we know our patients exist outside of our doors at Kaiser Permanente, and how do we support them in a setting in which they may be getting information from multiple sources. Identity, one of the biggest things, so much a shift in identity they go through when this surgery. Their body literally transforms, and so does oftentimes their mind. In terms of systems navigation, this is something we heard a little bit more operational. They're like, I just didn't have a great experience. I didn't know where to go at Kaiser. I didn't know how to get support. So that trouble with systems navigation was a really important takeaway. Mental health and trauma. This came out loud and clear from probably every single member we talked to, and how much mental health mattered in this surgery. And actually, our data even showed there's a higher history of trauma when we looked at adverse childhood experience scores among these patients. Maintenance was that long-term. A lot of our post-surgery patients mentioned that they started to regain at 5 or 6 years, and how do we actually support them at that time? Continuity is somewhat related to that maintenance, because one of the things they said to us most often is we give them so much information to prepare them, but when they really needed that was in that post-surgery end. And the last big insight was that self-care piece, and how that is taken very different across different populations and different cultures. We did a co-design in Spanish and really had very different insights when it came to self-care and what that means for someone than we did with our English-speaking population. So that brought us to developing design principles, which I won't even go into today, but if you're curious, you have this deck, or I'm happy to chat always. But that brought us to our imagine phase, where we worked with our patients and our providers to really think through hundreds of different ideas. We had so many ideas. We looked at them against what mattered to patients versus what was actually feasible to Kaiser, and we voted on them together. You can see some storyboards there, and there kind of were top two ideas that came out of all of this when we kind of voted and came and collapsed everything together, which was something that was online that could be at people's fingertips and something that helped them engage in person or at least in a live session to kind of continue skill building and support long term. So I want to highlight, then we moved into this kind of prototyping phase, the kind of last phase on that compass, where we really rapidly tested really low fidelity prototypes. Angela and I went out to our medical centers across Southern California and had people interact with paper websites and virtual setups versus an in-person setup and different types of skill building programs. And we did a series of prototype sessions where we actually had people test our products and think about actually how they would work in real time. So we got a ton of feedback. We failed real fast, but then we really came to a solution that ended up is implemented now. So this is the final prototype. Before I show you the final product, I'll have Angie kind of talk a little bit about operations, but kind of the 4 key components that came out of all this work was the first a pre-surgery workshop series to really help support patients and prepare them. The second was a long-term engagement group to continue that support. The third was a website or kind of something that's at their fingertips 24/7. And the last is our wellness coaching by phone program, which we leveraged and actually trained them in bariatrics. So they had some type of one-on-one coaching that was more personalized. But before I share the kind of final product with you, I'm going to turn it over to Angie to talk about how we incorporated our staff and our operations into the actual design of this.
Awesome. Thanks so much, Kelly. So from the very start, as we went through learning the methodology of human-centered design, we decided we were going to apply it to every aspect of this project. And so that included operations. And I think people understand applying human-centered design and all that comes with it to the development of the program. But when we come to operations, it elicits some hesitation, some confusion, and even a little resistance. But what was so amazing as we went into the understand phase and really tried to understand their experiences and turned our staff into a secondary customer that was getting the same attention, how eyes were opened and we were seeing the gaps and the areas of improvement. And really our goal here in doing applying this methodology to the operations was to take that final prototype with patients and make sure our system was ready to receive it. As we go into the reframe, you see we introduced or reintroduced what we learned from our members. And so they had identified systems areas of need of improvement, as Kelly was mentioning with the systems navigation. So we grounded ourselves in that experience. And what was so wonderful is that at the end of the day, our members, our patients are everyone's focus, regardless of what end of the spectrum you're on. So from surgeons to educators to managers, everyone was connecting with this common focus. What we learned from our surgeons was, they were focused on 5-year weight loss outcomes, readmission rates, resources for their members. From managers, they were worried about access and staffing needs and training and onboarding new staff. And our educators were really wanting to know how they can best care for their members, give and reduce the amount of background work they're doing and increase the amount of direct patient care they're providing, as well as being prepared for crisis management situations that arise in class. And so together we collectively developed several operation-related deliverables that we'll go through in a second. But we took a minute to make sure we defined key metrics for both KP and our organization, as well as our patients. And you will see some crossover here. So you see weight loss, you see quality of life, and on our KP end, we're looking at readmission rates and patient satisfaction. And so they relate, but they're also different. And so we really spent some time to make sure our evaluation processes are set up to answer and speak to all of these metrics that matter, not only to our organization, but to our members, to make sure the program is doing what it was created to do. And so that takes us to the outcomes of our operational co-designs. We focused on operational efficiencies, tools for our staff to deliver this program, Well, our training model, we really were focused on a sustainable model, especially mid-pandemic. We had to be. So how can we make a sustainable model that really focuses on knowledge, skills, and application? And based on what our members shared, our employees needed more training around weight bias and trauma-informed care. And so we infused the training with those and continue to revisit them with our teams across the region. And so that brings us to our final product. So as Kelly had mentioned earlier, those prototypes have now been operationalized and we're ready to implement. So our component one is our pre-surgery workshops delivered both virtually and in person. Here you have a gallery of the resources our members are experiencing. We worked with our amazing designers. We are blessed to work closely with designers to make sure with this patient population, portion size is staged and an important piece. And so how can we represent that? And so our designers did a beautiful job, as you can see, of making those pictures to scale for our members to make it really real as they're navigating that. Support group. So you'll see here a gallery of resources and tools that we're using in our support groups. Really our focus is creating a inviting and welcoming environment to get support. In the midst of a pandemic, we've gone virtual, and so our patients have more support on a daily basis than we've ever been able to deliver, which is a very exciting win for us, the silver lining of what we've been through this year. Our website, ready to launch in a couple weeks, and here's a gallery of what our patients will be experiencing when that goes live. So you can see some examples of that. And then our last component, component 4, our wellness coaches have been trained in bariatrics and are actively currently delivering care to our bariatric population in supporting them on their health journey. And so that is our final product, and I'm turning it over to Kelly to go over takeaways and tools. Thank you.
So we wanted to just end with a few lessons learned and practical takeaways, again, from that former non-designer perspective. And that's important because, again, our background is in public health and health promotion, policy change, systems change, but this using human-centered design has truly transformed, I think, the way both Angela and I as public health practitioners. So starting with the fact that HCD has essentially transformed the way we do strategic planning. I think one of the biggest things, we're trained as public health practitioners to look at internal, external threats, align metrics, values, goals, and really look at public value. But HCD as a framework helped us do that along the way, and it made strategic planning for what we actually want to do and achieve and accomplish really helpful. The second piece is that we used our data to really inform how we did human-centered design. So public health surveillance data at Kaiser, we're really lucky to have amazing aggregate data on our patient populations, but it helped us pinpoint those disparities and make sure folks who were struggling or maybe minorities that we haven't reached out to before are at the table. We were able to use our data to really inform our HCD process and make sure those folks that maybe aren't always there, their voices were heard. It also helped us build consensus and drive change management. Sometimes folks think about, we need a change management strategy for this after they develop a product, but human-centered design, we brought everyone along the journey with us, and it made it so much easier to build consensus, especially across surgeons, bariatricians, across 13 different medical centers in Southern California, and it really made the process a lot easier and honestly more fun. You saw Angie align those metrics that matter to the organization with those metrics that matter to patients, and that was so much easier to do and really pull apart and tease apart. An important one here is also this helped us shift away from a medical model mindset to whole person care. And it helped us make the case for actually doing that because they heard from our patients in the same room. And we had so much data from our patients to actually say, actually, that didn't work, and we've tried that in the past. And lastly, it just made our jobs, again, way more fun. I will speak for Angie for that too. The last thing I want to share is we have built out some very cool mural boards with our design team and templates here for designing in virtual spaces, especially with massive groups of people. This is just a huge snapshot of our kind of home board that's linked to a lot of different boards for our different phases of human-centered design. So if you have any interest, here's a few snapshots of them. That template is linked in our presentation, or happy to chat if you guys are interested in that. But all in all, we just learned how valuable designers are to healthcare and public health. So thank you guys for doing what you do, and we need you. So thank you guys for the time.
Awesome. Thank you so much, Kelly and Angela, for joining us. And we do have time for just one quick question. And I saw a great one show up in the Q&A tab from Meng Yan. And she is asking, are there any learnings that non-designers see or saw, but the designers didn't see it? So basically, is being a non-designer sort of an advantage? Did you see the world with fresher eyes or have a different set of assumptions?
That's such I love it. I guess I can take a stab at that. I think what I saw, honestly, I don't know if this makes any sense, but kind of what we were trying to say with our talk today is like the things that we do in public health or the ways we're trained in medicine it's great, but it misses sometimes that human factor. So for me, the biggest thing I took away from all of this was, oh my God, human-centered design makes my job so much easier, because we're often thinking about, well, what do we need to do? How do we plan that? But people often give us the solution. So I don't know if that makes any sense, but as a non-designer, I just saw how aligned these were and wish that this was taught in public health practitioner and in medical schools, just how you do this well. That probably doesn't answer that question, but
no, that is perfect. Thank you again, Kelly and Angela. And I encourage anybody, if you have more questions for Kelly and Angela, to connect with them via the chat. And just so you know, if you're not speaking, you don't have to share your video and audio. Only the speakers share video and audio. That's not because I don't want to see your beautiful face. It just makes it easier for me to find the speakers. So yeah, thank you so much, Kelly and Angela.